Good morning, and today's lecture is going to be on clinico-pathological aspects of colorectal cancer. And at the end of this lecture, you will be able to describe the pathogenesis of colorectal cancer, and you will be able to list out the clinico-pathological features of colorectal cancer and how it relates to the morphology of the tissue and the site of the tumor, and the macroscopic and microscopic appearance of the colorectal carcinoma. So let's take a clinical scenario first. And there was a patient who was 60 years old, a male, who complained of on and off constipation and loose stool, so there was alteration of bowel habits. And he has noticed that he passed a little bit of blood with the stools, and so he presented to the outpatient department with all these complaints, and the surgeon, the doctor who seen to his complaint, referred him to the surgical clinic. And the surgeon decides to take an endoscopic view of this, whatever the lesion in the lower gastrointestinal tract. So they went ahead and did an endoscopy to find that there's a growth in the rectal region. So he underwent a resection, that was an abdominoperineal resection, and finally they identified this adenocarcinoma to be spreading to the lymph nodes as well. So he was followed up at the oncology clinic, and at about 3 years later he developed metastasis in the liver. So that's the case scenario, and let's take one by one. So what is a colorectal cancer? Colorectal cancers are mostly adenocarcinomas, and it represents about 15% of cancer-related deaths in countries like Western countries like United Kingdom and United States of America. But the incidence is low in Asian countries like ours, and the peak age of presentation is generally between 60 and 70 years, and only about 20% or less than 20% will present when they are less than 50 years of age. And often the males are affected and less frequently in the females. And as I told earlier, it's more common in the Western countries. But still it is developing, or the incidence is increasing in the Asian countries as well. Probably because of the dietary habits that are changing towards the Western style. So how do one develop a colorectal carcinoma, the pathogenesis? So if you take these colors, the one which is starting with high fat intake, they think that because of high fat intake, you develop a lot of cholesterol or generate a lot of cholesterol and bile. Therefore, the amount of cholesterol and bile that is there in the gastrointestinal tract is high, and those are generally converted to carcinogens by the intestinal bacterial flora. The other reason is people tend to take a lot of low fiber diet, especially in the Western countries, so that their stool bulk is less and the stool does not progress forward, and they are there in the gastrointestinal tract for a longer duration. Therefore, whatever the toxic oxidative material or substances, the byproducts that are formed during this passage of stools through the intestine, can damage or can exert their effects with having a lot of time for their effects, and those oxidative byproducts remains in contact with the mucosa of the gut for a longer duration. So these oxidative byproducts can bring about mutations or damages to the gene. So one way is that because of the reduced fat fiber content, there is high fat intake, all that is directed towards mutations in the mucosal epithelium. The other reason they have found is there can be deficiencies of vitamin A, C and E, which are generally considered to be very good free radical scavengers. If there is a deficiency in vitamin A, C C or E, there will be lesser number of amount of scavengers in the gastrointestinal tract, so that the oxidative byproducts can exert their effects without any problem. So that's one which will again sort of compound the effects of having low fiber diet and high fat intake. And the other important reason is that this is seen in a minor proportion of patients, that is familial polyposis coli, where young people are having a lot of polyps inside or over the mucosa of the gastrointestinal tract. And finally, because of the mutations in the APC gene and a lot of a chain of genetic changes, they end up with colorectal carcinoma. So this shows how normal epithelium becomes a carcinoma. The very first one is the normal epithelium. Due to methylation abnormalities, it becomes a mucosa at risk, and due to proton gene mutations, there can be altered mucosa with dysplasia, which grows and becomes an adenocarcinoma. Now you can see that this adenocarcinoma is growing towards the lumen, and it is not infiltrating down into the submucosa. But the moment they get another gene mutation, it becomes a carcinoma, where the tumor infiltrates down into the wall and it can even break through the submucosa and infiltrate out. So this is, we call this is the adenoma carcinoma sequence. So that is how a normal mucosa of the colon becomes a carcinoma finally. So how do they present? Presentation is also different sometimes, because the right-sided cancers are presented differently and left-sided in another different manner. Often the cancers in the cecum and the right side of the colon grows without the patient's knowledge, and the patient the cancer may be bleeding into the colonic cavity for over a long period of time, and the patient finally comes with iron deficiency anemia. He may not complain of anything to do with the abdomen or the gut, but will be having pallor, and on the blood picture that you find some evidence to say that it's iron deficiency anemia. So in the age group of like over 50, when people come with iron deficiency anemia, the doctor needs to go ahead and think of if the patient is having gastrointestinal carcinoma. But the left-sided colorectal adenocarcinomas present differently, because as you know, the left-sided part of the colon gets more semi-solid, like stools. It's not liquid. And the other thing is, left-sided colonic carcinomas are often obstructive, or they grow into the lumen and it encircles the colon, so that they often present with intestinal obstruction. They may have bleeding, like in the rectal carcinomas, because if there is a tumor in the rectum, due to the whatever the damage from the hard stool, it causes some damage to the surface epithelium of the cancer and it starts bleeding. So that is often very fresh bleeding, that's not altered blood. So the right-sided colonic carcinomas and left-sided colonic carcinomas present differently. So this picture shows the very first one, A and B, is the macroscopic appearance of a colonic carcinoma. You can see what is in red, very much in red, is the cancer, and it has gone into the lumen, and that has very friable tissue. That's why with the stools damaging the surface, that's why it causes bleeding. And the next one, the B, in the same box, shows the tumor which has infiltrated into the bowel wall. And this is a picture of the microscopy, that's what the pathologists see as colorectal carcinoma. They are the glands that you see lying by very dysplastic epithelium. These are not the normal glands that we get in the normal colon. So these are very infiltrating glands. So that's the microscopy. So after some time, even if they are treated, if their tumor has infiltrated elsewhere, or maybe some scattered cells are remaining, they can develop and the patient gets metastasis. The very first one shows microscopic picture of colonic carcinoma in a lymph node. These two, that's the macroscope. And there's the liver. This is what has happened to the patient in the case scenario. He would have had these metastases, what is in yellow, these necrotic masses, multiple nodules in the liver with the colorectal metastasis. So just to summarize how colorectal carcinomas can present and the clinico-pathological features, they are generally seen in people who are more than 50 years, and there can be patients who are presenting at a lesser age, like in young 40s, 30s, but they are very often associated with familial adenomatous coli. And then the clinical presentation can differ depending on where the colorectal carcinoma has developed. Is it a left-sided one, or is it a right-sided one, or is it a rectal, pure rectal carcinoma? So if the patient comes early and they undergo resection early, they will be fine. But if they have lymph node metastasis or already had got liver metastasis, their prognosis is not so good. So thank you, and that's how a patient presents to you with a colorectal carcinoma.